Hello, my name is Carolyn Abbott, and I will be presenting case study number 23, esophageal varices. Chief complaint. Mr. PT is a 62-year-old accountant who was found by his neighbor unconscious and lying face down in a pool of bright red bloody vomitus. He was resuscitated and transported to the hospital by EMS and admitted to the intensive care unit. Mr. PT is being admitted for acute gastrointestinal bleeding. He was hospitalized for a similar episode 5 weeks ago. An endoscopy was performed at that time, and it was significant for a bleeding esophageal varix, and he underwent banned litigation therapy. Mr. PT is well known for his chronic alcohol abuse. He was also diagnosed with alcoholic cirrhosis 5 years ago. Esophageal varices are dilated submucosal distal veins that connect the portal and systemic circulations. A variceal rupture is the most common complication of cirrhosis that leads to death. The two major events that lead to an increase in portal pressure in the liver are increased resistance to portal flow and an increase in portal flow volume. Clinically significant portal hypertension is one of the main triggers for the development of esophageal varices. Portal hypertension is most commonly a result of cirrhosis of the liver. As the amount of fibrotic tissue increases, it leads to increased intrahepatic resistance to portal flow and ultimately an increase in portal pressure. Increased intrahepatic vascular resistance, increased blood flow through the portal vein, and a collateral venous system ultimately result in angiogenesis and the formation of collaterals between the portal vein and systemic circulation. They form in an attempt to decompress the increased pressure inside of the portal access and return blood flow to the systemic circulation. Esophageal varices are present in approximately 50% of patients who are diagnosed with cirrhosis of the liver. Portal hypertension causes portocaval anastomosis to develop in an attempt to decompress portal venous circulation. The portal venous system has no valves and passively accepts blood flow from the splenic vessels. Any resistance between the splenic vessels and the right side of the heart results in retrograde flow and elevated pressure. The elevated pressures result in a diversion of the blood flow into the systemic circulation through the formation of collaterals between the portal vein and systemic circulation. These portosystemic collaterals act as low resistant outflow channels in an attempt to decompress the portal venous system. The increased resistance to portal flow worsens with increased intrahepatic resistance due to fibrosis that can originate at the sinusoidal, hepatic, or portal venule levels. Mr. PT was admitted to the ICU for a diagnosis of acute gastrointestinal bleeding. He has been hospitalized 5 times in the last 30 months. The last admission was for treatment of bleeding esophageal varices. He has lost several jobs and his driver's license for drinking on the job and drunk driving. He and his wife are currently separated. He has a 44-pack year history of smoking. He was diagnosed with alcohol cirrhosis 5 years ago and drinks an unknown amount of liquor a day. He also drinks 1 to 2 packs of beer per day. He has been admitted in the past for pancreatitis, alcohol withdrawal, seizures, ascites, coagulopathy, esophageal varices, peptic ulcer disease, anemia, and gastritis. His medications include lactulose, spironolactone, furosemide, propranolol, and famotidine. His initial vital signs upon admission were temp of 98, pulse of 112, respiratory rate of 14, and a blood pressure of 90/60. The physical exam is significant for the skin being markedly jaundiced with spider angiomas on both arms. He has a normal skin turgor. His HENT shows icteric sclera. Pupils are equal and reactive to light and accommodation. His intraocular movement is intact. His TMs are intact. His neck is supple and negative for JVD, thyromegaly, and lymphadenopathy. His chest clear throughout with good air exchange, and it's positive for gynecomastia. His heart, he's tachycardic with normal rhythm. His abdomen is soft with mild distension. He has hyperactive bowel sounds, positive splenomegaly. General rectal exam, normal genitalia, and heme positive stool. His extremities are warm with mild 1+ edema. Pulses are 2+ and symmetrical. His neuro, he is alert and oriented ×4, but he is slow to answer questions. Hospital course, a central line was placed and octreotide was initiated to stop the bleeding. The patient underwent an endoscopic procedure and his bleeding varices were sclerosed with sodium morolate. Although it can be challenging, a Christian nurse practitioner must first treat an alcoholic patient with the same dignity and respect and compassion that Jesus showed to us. It is important to remember that alcoholism is a disease, and therefore we must approach the patient with empathy and understanding. By using a compassionate and informed approach, we can help patients affected with alcohol abuse by reinforcing the idea that alcohol abuse is a disease in need of treatment in a non-judgmental or condescending manner. They are more likely to accept the treatment that we offer them. My case questions are as followed. What is the significance of the liver enzyme test results? Explain the pathophysiology of jaundice and icteric sclera. And why are diuretics like furosemide and spironolactone appropriate for patients with chronic hepatic disease? Thank you.